Avnish Katiyar, please.
Avnish?
Hello, Avnish.
Hello, sir.
Hello, Avnish. Yeah, you are audible.
Avnish, kindly share your screen, please.
Yes, sir. Sir, is it
Yeah.
visible?
Yeah.
Good afternoon, respected chairpersons, faculties, and my colleague. I am Avnish Katia, senior resident at M. Rishikesh. Today, I am going to present my paper, a comparative study of surgical fixation versus non-operative management in multiple fractures in outcome analysis. As we know that blunt trauma chest is second most common cause of death among all trauma patients, which consist up to 97% patients having rib fractures in all thoracic trauma, starting from isolated rib fractures to the flail chest, which constitute up to 5 to 7% of all thoracic trauma. And the most common recommended treatment for the all rib fractures were non-operative. But few recent studies they are showing that surgical fixation as a may be beneficial in few selected group of patients like flail chest and highly displaced rib fractures. So we plan a prospective pilot study at our institute from November 19 to May 2020 for duration of 18 months. Inclusion criteria were more than 2 displaced rib fracture following blunt trauma chest from age of 18 years to 80 years. Exclusion criteria were open contaminated wound at the fracture site, uncontrolled diabetes, hypertension, and severe head injury of Jesus less than 8, associated life-threatening injuries like hemorrhagic shock. All blunt trauma patients presented to us in emergency department, they were managed as per ATLS protocol, where life and limb-threatening injuries were dealt first. After applying inclusion and exclusion criteria, patients were enrolled in the study. All patients, those are enrolled in the study, were explained about surgical and non-surgical management. And the patients, those who gave consent for the surgery were enrolled in the operative group. Other patients that were enrolled in the non-operative groups. And management for both operative as well as non-operative group were hypoxia was managed from oxygen to the invasive and non-invasive ventilation. Pain control, we used IV analgesia round the clock. And in other patients, we used intercostal as well as cerebral blocks and transdermal patch of buprenorphine. Epidural catheter were used in all patients until it's contraindicated. Chest therapy, early mobilization, and supportive treatment given to the all patient group. And in operative groups, written and informed consent were taken. For pre-operative planning, 3D reconstruction of the thorax was done, and the marking for pre-operative remarking was done at anatomist table. Anatomist table is a 3D anatomy virtual visualization system we have for pre-operative marking to identify the displaced rib fractures and number of rib fractures and pre-contouring of reconstruction plates. We use reconstruction mandibular plates of size 2.5 mm, and we use minimum 3 screws for fixation of each segment of the rib. Come to the result, total 168 patients presented to us during the study, and 37 patients were enrolled in the study. Rest of the patients were excluded after applying exclusion criteria. And total patients, 17 patients were in the operative group and 20 patients were in the non-operative group. We monitors outcome in terms of length of hospital stay, length of ICU stay, pain control, and incidence of pneumonia. The outcome analysis was done by using Mann-Whitney U-test, and significant p-value was taken as 0.05. We noticed that the length of ICU stay and pain control at the discharge was significantly lower in the operative group as compared to the non-operative group, while the length of hospital stay and incidence of pneumonia was lesser but was not significant. So come to the discussion complications, they are directly related to the number of refractures, type of refractures, and the degree of displacement. Long-term patient reported outcomes in the surgical groups were reported better as compared to the non-operative group, and few studies the favors that surgical fixation having better outcomes in terms of length of ICU stay, pneumonia rate, and ventilator days. in surgical fixation group, especially in cases of flail chest. So surgical fixation have lesser ICU stay and require less analgesia after fixation. Long-term pain control and deformity was lesser in the operative group. So recommend that surgical fixation is better in the flail chest and displaced rib fractures. More randomized controlled trials and meta-analysis are required. Thank you for patient listening and kind attention. Thank you, sir.
Thank you, Avnish. Nice presentation. Am I audible to you?
Yes, sir.
I have one question for you. You said about study design. You call it as a pilot study. Why you are saying it is a pilot study? Number of cases were, I think, much. When you initially enrolled, it was 160, but finally there was something 30 plus.
Sir, it was a. Sir, am I audible? Sir, it was.
Yeah, you are audible.
Hello.
Hello.
Thank
Yeah.
you, sir, for asking a nice question. Actually, this was the data of all trauma patients we received. So overall, we included this for enrollment in the surgery, but it was 37 patients. So we were expecting that surgical fixation. It's very difficult to randomize the patients in that surgical group and a non-surgical group. So we were planned a pilot study that if patient will be willing for the surgery, then we'll include in the operative group. So that's why we designed the pilot study in our.
Okay, you mean say you were not sure how much patient will give consent for this study. That's why you say it is a pilot type study.
Yes, sir.
I have one question.
You are not other term, what term can be used for the study design in this case?
So pardon, sir. It's not a question or not audible.
I am saying instead of pilot study, what other term can be used for study design?
So it could be the observational study that or
Yeah, you are right.
prospective interventional study we can.
Oh, good.
Okay.
Any more questions from chairperson?
Okay,
I've
we
got
have
one question to Avnish.
Yes, sir.
Which rib fracture you counted? Like upper ribs, it's very tough to like first upper two ribs. It's very tough to have. Operative site is very difficult, and lower ribs
Sir,
you
we
don't fix
excluded
it.
the floating ribs and sir, we excluded the floating ribs and the first two ribs.
Okay,
for the
that was in
fixation.
your not
We used
mentioned. I think in exclusion criteria.
So we
Yeah,
did
just,
isolated rib fractures there. Then we use if it is more than two ribs. It is mentioned that if it is more than two ribs, then we already excluded this. If it is more ribs, then already it come into our study criteria. If they are like first, second, third, fourth, then they already come to our exclusion criteria. So we will exclude first two ribs, and that is because they are very difficult to access, and they are mostly stable because of muscle attachments.
Okay.
okay, just as a time machine, sorry, we have time. Can we move to the next presenter?
Thank you, sir.
Thank you.
Thank you, Dr. Avnish. Now I want to call Dr. Nikhil Kumar Singh for his presentation. Dr. Nikhil, you have 5 minutes for your presentation and 2 minutes for your discussion. Dr.
Hello, sir, am I audible?
Yes, you are audible.
Okay, sir. Good afternoon, respected judges. Sir, I will be presenting my study of optic nerve sheath diameter guided optimal mannitol therapy for reduction of intracranial pressure in traumatic brain injury patients, sir. Sir, background coming to the introduction, sir. Osmotherapy has been the cornerstone of medical management of the raised ICP following traumatic brain injury patient in ICU. Optimal dose and duration are very important using mannitol therapy to avoid any side effect. Measuring the optic nerve sheath diameter with bedside ocular ultrasound detects the raised ICP, and mannitol therapy can be tailored accordingly and avoid the side effects. A cutoff more than 0.48 centimeter was corresponding to ICP values of 20 centimeter of water. So it was a prospective randomized case control group study. Ethical clearance was obtained and the trial was registered. The inclusion criteria involved the patients between the age of 10 to 60 years of either sex, of ASA physical status 1 and 2 with GCS less than or equal to 8, history of TBI, and patients who were not candidates for the decompressive surgeries were also included. The exclusion criteria involved the patients of less than 10 years or more than 60 years with panfacial trauma or with severe ocular injury, and or with patient with CT or MRI features suggestive of impending globe rupture. So, sir, in the control group, that is the group 1, we use the conventional mannitol therapy of 0.25 gram per kg, 6 hourly or 8 hourly, and continued based on the clinical assessment of the raised ICP. In my study group, that is group 2, we use the optic nerve sheath diameter assessment at admission and every 4 hourly, and mannitol was given whenever the optic nerve sheath diameter was more than 5 mm. An additional bolus of mannitol was given on when the optic nerve sheath diameter crosses the limit. So the total dose of mannitol should not be exceeded 200 gram per day. And when 3 consecutive optic nerve sheath readings were less than 5 mm, further assessment of the diameter done was increased to 12 hourly to detect any rebound increase in ICP. Mannitol administered anytime when the optic nerve sheath diameter more than 5 mm, and therapy stopped if the diameter continued to be less than 5 mm in 6 consecutive readings. So statistical analysis was done by SPSS version 17. Sample size was calculated with power 90% as 21 patients were coming to the group, but we included 25 patients to account for the dropouts. Comparison of the normal distributed continuous variables between the groups were student t-test and nominal categorical data between the groups by chi-square test or Fisher-Exec test as appropriate. P-value less than 0.05 was considered significant. So we can see in the result that the age group distribution was p-value with 0.622, which was not significant, and sex distribution was also not significant enough. Now coming to the results of the comparison of the total number of doses of the optimal mannitol therapy utilized, we can see that the day 1 and day 2, though by using of the optic nerve sheath diameter, we have to give the mannitol more, but in overall total duration of 5 days, the mannitol required by use of this diameter tailored approach was less than the conventional one. Or similar trend of the doses, we can see the control group over day 1 to day 5 that the total cumulative dose we given was 12.72 up to day 5. But in the study group, it was 10.12, which is significantly less. So, sir, coming to the discussion that severe TBI is classified as acute phase at post-resuscitation, and GCS score of 3 to 8 with mortality of 20 to 30%. And after primary brain injury, goal of treatment was always to prevent the secondary brain injury. By the Monro-Khalil hypothesis, we can see that initially there is high compliance and the compensation is well. So we are quite good over that. But as the time progresses, the compliance started decreasing and the compensatory reserve gradually depleted, and ischemia and risk of ischemia and herniation starts. So there are a few type treatments. First of all, we have to sedate.
Dr. Nikhil, we have just 1 minute remaining.
Okay. Sir, there are 2 types of treatments, sir. We can use barbiturate, bifrontal decompressive craniotomy, that are second tier. And in first tier, we can use the osmotic therapy. There are various osmotic therapy agents available. So mannitol osmotherapy we can give, but there are side effects of the decrease hypotension, then hypernatremia, then cardiac failure. All these are the side effects of the mannitol. So how can we measure the optic nerve sheath? We can see the at a distance of 3 mm from the posterior globe segment, and we can measure the optic nerve sheath diameter, which is normal of less than 4 mm in infants, less than 4.5 mm in children, and less than 5 mm in adults. So during our study, requirements of mannitol on day 1 in study group was significantly higher as compared to the...
We have time.
Okay, ma'am. Okay, sir. So finally, I would like to conclude that ocular ultrasound guided osmotherapy for raised ICP significantly decreases the dose as well as the duration of the unmonitored and excess osmotherapy. So by the use of this, we can avoid any side effects and excess dose of mannitol. Thank you, sir. These were answers.
Okay, thank you, Dr. Nikhil. Now session is open for discussion.
Dr. Nikhil,
Yes, sir.
you measured the optic nerve diameter by ultrasound, right?
Yes, sir. Linear
So was it
focal.
the same person who was examining the patient at different times, or were it different people handling the probes?
Sir,
at
this
different points
was
of time?
a drawback in the study, sir. We were 3 persons, sir. At the different duties, we used to do that, sir. It was not the same person, sir.
All right, because measuring the optic nerve diameter
Yes,
can
sir.
be different for,
Yes, sir.
just
Definitely,
measuring
sir.
it, putting the probes inside and markers inside and outside can be very well differ.
Yes, sir. Definitely, sir. But this was a limitation we could not.
All right.
And Dr. Nikhil, what was the frequency of doing monitoring optic nerve diameter? Like how frequent?
Sir,
you were-
it was initially, sir, initially it was 4 hourly. We used to check, just see that 4 hourly, it is okay, it's okay. And when after 3 or 4 readings, sir, it came to be normal, less than 5 mm. Then we started gradually 8 hourly. And then when 5 readings are normal, then we did it 12 hourly, until unless there is some clinical signs like patient's brady or hypertension, something suggesting that the patient is getting ICP raised. So we started again doing 4 hourly, but hardly it was needed, sir.
And what about the patient with severe brain injury who required LASIK also? In top of along with mannitol, some of the patient require LASIK. So you excluded that patient, or you counted that in?
No, sir, we didn't excluded LASIK. Sir.
Okay. Thank you, Nikhil. You have
Thank
time
you.
now.
Thank you, sir. Thank you so much.
Yeah, just for information, I'll tell you that the third presenter, Dr. Ramesh, because of technically he's not available right now, so we can move to the fourth presenter, Dr. Ruchi. Okay. Madhur.
A very good morning to everyone.
Well, very welcome, Dr. Ruchi, for this session. And you have 5 minutes to present your session, and 2 minutes there will be there for question and answers. So I hope we stick to the schedule, and best of luck with the presentation.
Thank you, Dr. Madhur. Respected chairpersons, all the faculty members and delegates, a very good morning to one and everyone. I'm Dr. Ruchi Kaul, a maxillofacial surgeon with special interest in medical 3D printing. Today, I'm coming from the Trauma Center, AIIMS, New Delhi, where the center runs with 4 limbs. This is the pre-hospital, hospital, treatment, and rehabilitation limb of the Trauma Center. So I'm going to present in front of you in the next 5 minutes, 3D technology-assisted workflow to strengthen the rehabilitation limb of trauma care. Now, 3D technology is a layer-by-layer deposition to create a 3D object. It's also called as additive manufacturing. As you can see on the right picture, the 3D printer is moving and a layer-by-layer deposition of a polymer happens to create a model. The person right below is the father of 3D printing technology named Charles Hull. Now, 3D technology was accepted by aerospace industry and automobile industry way back in 1980s. But in the surgical world, it has been coming up a little late. So in surgery, across all specialties, we can use 3D printing for 4 types: contour models, guides, splints, and implants. Besides benefiting different specialties, 3D printing can also help in patient education and care, novel research and innovation, and it is a futuristic expansion to a bioprinting lab. This study was conducted at the Division of Trauma Surgery and Critical Care, JPNATC AIIMS, New Delhi, and Indian Institute of Technology, New Delhi. This is a clinical trial and has not yet been done in India. Group 1 was the patients with post-traumatic mid-phase defects requiring multiple reconstructive surgeries, while Group 2 was acute mid-phase trauma. Yes, sir. After taking institutional ethical clearance and CTRI registration, fulfilling the inclusion and exclusion criteria, the patients were enrolled for the study. Now, this was the first case where a 29-year-old male with a road traffic accident in the year 2015, who we operated in the year 2018. He was the only survivor of the 4 people in the car. The defect, as you can see in the second picture, which is B, is the right alveolus was missing along with some part of the left side. The patient was advised to go for an iliac rest, but was not ready for a second surgery and for creating of a second defect. And therefore, he wanted to undergo 3D planning as was explained by us. The patient was enrolled and we went for model preparation where we could easily show the defect, followed by implant creation on a software, and then surgically operated the patient and gave him finally the teeth to reconstruct and rehabilitate the patient. The entire process took us around 3 to 4 months as this was the pilot case. I would like to show you this video where we can say that we did a virtual planning. And as you can see, we divided the skull into 3 parts in 3 planes. And after we placed the implant, we actually calculated how much we moved the entire facial reconstruction, or you can say the outer boundaries ahead of the original structure. With this first case, we actually standardized the processes which were involved, which include the radiological processes like the CT or the CBCT. We selected the softwares, the printers, and the regulatory documents along with outsourcing considerations. After ethical clearance and patient enrollment, once we had the CT scan, we called the patient directly for the actual surgery. And therefore, right from the CT scan up to the design which was finalized, the whole process was at the bench. And therefore, we could plan the surgery better. It was more predictable, and we achieved better results. The
1 minute
CT scan
remaining.
thickness, the CT scan thickness is 0.6 mm slices, which was choice for our radiological investigations, because we could use FDM technology-based printers for accurate dimensions. There was significant increase in the operative time in hospital stay, and therefore no significant difference between the conventional model and the 3D planned model. Quality of life was drastically improved in the first 3 months, and we were able to decrease the surgery by at least 1 surgery, with each patient being given a customized treatment. There were a lot of studies which we found that did agree with the results that we had. So the conclusion was that operative time in hospital stay was definitely decreased with long-term cost effectiveness, because we could decrease 1 surgery. We were easily able to diagnose the patient and come to a treatment planning. With respect to patient benefits, there was precision, customization, reduction in the number of surgeries, and improved quality of life. Future prospects of 3D printing are teaching and training across specialties, prototyping for innovation. I would like to say, this is a picture from the Mayo Clinic, which I recently saw, and I had a word with surgeons operating in the Mayo Clinic. And when I saw this picture, what came to my mind was that if in the Mayo Center they could do this, even we can do this. Thank you for patient hearing.
Thank you.
Very well presented, Dr. Ruchi. Just wanted to know what was the final implant made up of?
Titanium. That was medical grade titanium.
So you use the 3D printing for the mapping, and then you translate it into titanium.
So we used it in all aspects, like starting from diagnosis, then treatment plan in the virtual surgery area, then designing the implant, and then finally printing.
All right. So now the floor is open for any questions.
Good afternoon, ma'am. Very nice presentation. I would just like to ask you, what is the average cost, average cost to the patient for a 3D printing? And as you said, it is long-term effective, but what about the initial cost? Could you please explain it?
So 3D printing is definitely an expensive technology. It has its cost, but this was a research study, so we did not charge the patient. But I would say, because if you can reduce even 1 surgery, so if you look at the cost in the long run, the patient has to go multiple surgeries because these are defects which require a lot of plastic surgeries. So even if I can reduce 1 surgery, the upfront cost is taken care of.
Thank you, Dr. Ruchi.
Thank you.
We might proceed with the next participant, please.
Yeah. The next participant, Dr. Ramesh, is online now. So I request Dr. Anand to kindly please introduce him and just invite.
Next is Dr. Soumya. Next is Dr. Soumya Ghoshal.
Ramesh, Dr. Anand, Ramesh is ready, I think. You can call
Yeah,
Ramesh.
yeah.
Okay. Now I'll request Dr. Ramesh to be ready with the presentation on emergency thoracotomy.
Am I audible and is my screen visible?
Yes, yes.
Yeah. Good afternoon to the respected faculty. May I start?
Yes, yes, please.
Today I'll be presenting my paper on emergency thoracotomy from an Indian perspective, a retrospective single center observational study. As we all know, emergency thoracotomy is one of the life-saving procedure performed during the initial resuscitation of the patients presenting to us at extremis. Although it's a life-saving procedure, it has a lot of controversy surrounding it. One among them is the nomenclature. So in our study, we have recruited emergency thoracotomy. What we mean is those thoracotomies that are done as an integral part of initial resuscitation process, irrespective of the place where it is done, either in the emergency department or in the operating room. So why do we require this study? Because the available literature on emergency thoracotomy are all from developed countries where they have a very well-developed pre-hospital services integrated to a trauma systems. In our country, the pre-hospital services and trauma systems are still in their infancy with very few well-maintained trauma registries. So the aim and objectives of the study was to study the pattern and presentation of patients undergoing emergency thoracotomy and to study the factors affecting outcomes of patients who undergo emergency thoracotomy. The methodology, it was a retrospective observational study conducted under the Division of Trauma Surgery and Critical Care, New Delhi, AIIMS. The study period was between October 2014 to October 2020. All the data were retrieved from computerized patient database and OT records. The sample size was 53 patients. So coming to the results, we had a total of 53 patients included during the study period, out of which 50 were males, and the mean age was 29.6 years. So the first graph here shows that the most common mechanism was penetrating assault, and the outcome was also better in penetrating assault, where about 36% of the 28 of the total had survival. Whereas in gunshot injuries, the mortality was 50%, whereas in blunt trauma, it was more than 60%. So coming to the division of mortality, our overall mortality among 53 patients was 25 patients, amounting to 47.1%, whereas in the established literature, it is 57.1%. Among the patients who died, 16 patients had an untable death, amounting to 64%, whereas in literature, it is about 60%, quite close. The rest, 24% died in ICU within 24 hours, amounting to early mortality, and 8% had later mortalities. The penetrating assault had a mortality of 37.5% in our study, whereas in literatures quoted below, it is 38.7%, whereas in blunt mechanism, it is 62% in our study, whereas 74% in other studies. One other important mortality predictor is the location of injury. So patients with isolated intrathoracic injury had a better outcome with a mortality of just 33%, whereas patients with exclusive extrathoracic injuries had a mortality of more than 85%. So these are the major organ involvement in our study, the majority being cardiac and the rest thoracic, and combined with the rest following the cardiac injuries. So we preferred a clamshell thoracotomy because of the ease of access and the wide exposure. Comparing the baseline characteristics and the vital parameters of the primary survey, there was no significant difference except for the patients with threatened airway who had a statistically significant difference and in mortality, probably because most of them were peri-arrest period, in the peri-arrest period requiring intubation. The average time to arrival from the injury in our setup was somewhere between 49 minutes in gunshot injuries to 155 minutes in blunt, whereas you can see that in a given literature, it is 40.5 as quoted below. The complications were the most common complication being pleural collection, that is in 4 patients, and followed by pneumothorax. The average hospital stay of patients who survived was 18.2 days. So coming to the conclusion, the most important factor determining the outcome of the patients undergoing emergency thoracotomy is mechanism of injury. That is, penetrating assault do very well as compared to blunt mechanism. In spite of fully developed pre-hospital services and trauma systems, our mortality rates are comparable to those in the literature. This is probably because of the strict selection criteria, which is as per the latest ATLS guidelines, and also well-prepared trauma team with a stringent in-hospital protocol for including departments like blood bank, anesthesia team, and 24-hour availability of the OT. The limitation of my study is that it's a retrospective analysis with limited number of patients and an incomplete logistic data for all patients. Thank you.
Now, house is open for discussion. Any questions from anyone? Please.
Ramesh, it's a very nicely presented paper, but I would like to ask you, what do you mean by Indian perspective in emergency thoracotomy?
That's what, sir. We don't have any data from this part of the country, and this part of the Asian population also having a literature on emergency thoracotomy is very less, because we don't have a pre-hospital system. Most of the data are from the Western literature, where they get the time of arrest, the time to arrival to OT from the pre-hospital care itself. But we don't have the things. So we thought that probably, does it make a difference in our outcome? Even without a well-established pre-hospital services, if we select the patients properly who require emergency thoracotomy, I think we'll be able to provide the same outcome as given in the literature, sir.
So that will tell, so let me ask you another question related to it. What was the commonest indication for emergency thoracotomy in our place?
It was penetrating assault, sir. Thoracic penetrating assault.
With what? With witnessed cardiac arrest. Were the indications any different from the West?
No, sir, it was all the same, yeah.
So the time, it is not related to the pre-hospital care. If you're operating with the same indications,
yeah,
like penetrating trauma, pulseless cardiac activity,
yeah,
or something like that. So it does not make sense. You could have simply written the topic as comparison from the Indian, Indian tertiary care center, because the facilities available in AIIMS Delhi ED are no different from any other ED in the world.
Yes, sir, I understand. But sometimes what happens is, in their pre-hospital setting, they say that the patient has coded and the time of arrival to the emergency department is 2 minutes or 5 minutes. So they are already prepared to do an emergency thoracotomy there. But whereas we don't get any information regarding that. So,
but you have not done any comparison with the time of the arrival to the outcome.
No, the time of arrest to the OT procedure also matters, sir. So we thought that, does it matter that
you are operating all the patients for the indications which are same in the West?
Correct.
Witness cardiac arrest, penetrating trauma, or even blunt trauma with pulseless electrical cardiac activity.
Yes,
so how
sir.
does the pre-hospital, that goes it out of the question? If you had taken the parameters like comparison, comparison with the pre-hospital time of injury or time of arrest, if you had taken the outcomes in that respect, it would have mattered. What do you think?
Yeah, sir.
Yeah, just may I interrupt here? Sorry. Just for it's a nice question, and Ramesh, you can take care of this in your further writing a manuscript or so. So yes, thank you, Ramesh, and
thank
just we'll move on to the next presentation. Thank you, Madhu.
Thank you, Ramesh.
Thank you. Thank you.
Okay, so I welcome Dr. Somo Ghoshal for the next award paper session, and he'll be presenting the outcome correlation of initial arterial blood gas analysis in isolated thoracic trauma. Over to you. Please unmute, Somo.
Hello, sir. Am I audible now?
Yes, you're audible.
Thank you. Respected all, the title of my paper is Outcome Correlation of Initial Arterial Blood Gas Analysis in Isolated Thoracic Trauma Patient. Here we hypothesize that the ABG parameters, that the initial ABG parameters in isolated thoracic trauma patient may alter due to alteration of the ventilatory status of the patient. So the question is, do really these ABG parameters on arrival predict outcome in isolated thoracic trauma injury patient? So the primary objective of this prospective observational study was to correlate the ABG values as well as the clinical parameters at arrival with outcome in isolated thoracic trauma patients at a level 1 trauma center in India. Now the outcome in this study, the primary outcome was hospital stay, and other outcomes were duration of ICU, duration of mechanical ventilation, and mortality. We included 164 patients of isolated thoracic trauma patients who were initially triaged at red. The sample of ABG were taken on arrival or within 30 minutes of inclusion of patient in the study. Those patients who are hemodynamically unstable, non-responder or transient responder, patients aged less than 18 years, and those patients who presented more than 24 hours of injury were excluded, and also injury to major thoracic vascular structure, esophageal, cardiac, diaphragm or spine injury patient were excluded from the study. 150 patients out of 164 patients were male, and most of the patients were in 30 to 44 year age group. And almost 18% of patients needed ICU admission on arrival or at later stage during their clinical course. So the median duration of ICU stay was 7.5 days, and the median duration of hospital stay, there is a primary outcome, was 4 days. Regression analysis showed that changes in individual ABG parameters were not significantly associated with the changes in duration of total hospital stay. Although altered initial ABG parameters were associated with need for ICU admission, but none of the ABG parameters predicted longer ICU stay or longer duration of ventilatory support. Metabolic acidosis was present in 40% of patients who needed ICU admission, and also lactate and base excess were positively correlated with need for ICU admission and institution of ventilation on arrival or at later stage. We constructed the ROC curve for each of the ABG parameter to determine the threshold level in predicting ICU admission, and we saw that the area under curve was largest with base excess in predicting ICU admission. Now, coming to the clinical parameters, if we see that strength of association between the clinical parameters and the length of hospital stay, there is a significant correlation. But in other parameter, that is days on, they could not predict the longer duration of hospital stay or longer duration of ICU stay. Along with ABG, they also could predict the need of ICU requirement, but could not predict the duration of ICU stay. Surprisingly, age had no influence on the outcomes. It may be because of that there is less proportion of patients in our study group who are in elderly age group, who are more prone for to polytrauma rather than isolated thoracic injury. Coming to the mortality, only 4 patients died out of 164 patients of isolated thoracic trauma, and 3 of them had metabolic acidosis and raised lactate and base excess level. All of the 4 patients were managed in ICU, but interestingly, 3 out of 4 patients were initially admitted in ward and later on transferred to ICU. The cause of death were ARDS and sepsis in 3 patients. 1 patient went into shock and expired following the installation of streptokinase in pleural space for managing retained pneumothorax. So in summary, among the patient parameters, patients ISS, NISS, RTS, GCS, respiratory rate on arrival, SpO2 had significant association on length of hospital stay, unlike initial ABG values. But both ABG parameters and clinical parameters on arrival were able to identify those patients who needed ICU admission and positive pressure ventilation. But initial ABG values neither changed the management in ICU or ward or nor duration of admission. although initial altered ABG parameters means patient needs more aggressive monitoring, more aggressive resuscitation, but the importance of a serial ABG analysis rather than a one-time analysis cannot be underestimated to detect changes in physiological status of the patient. However, we demonstrated that predictive value of those biomarkers is retained in isolated thoracic trauma, but initial ABG parameters can never replace clinical examination for decision making. Our study is not without any without limitation. Results are only generalizable to the trauma patient. Oxygenation status was not uniform in all patients, and presence of comorbidity was not studied. So larger scale is needed in future. Thank you.
Excellent presentation, Dr. Somu. I congratulate you for the study. I have just one question. You said that initial ABG, no parameter in the initial ABG correlated with the outcomes. But however, you say that serial ABGs are important.
Yes.
So your study, you are not quoting from your study, right? Because you have seen only the initial ABG. So this is you are telling that, okay, serial ABG is good. This is not a conclusion from your study.
Yes, sir.
Okay.
Obviously.
Any other questions to the other panelists?
So, Swam, how have you defined initial ABG? What does initial ABG?
Initial ABG is the ABG, the sample of ABG was taken at arrival on presentation when patient presented the red area. At that ABG which was taken on arrival, there is the first ABG which we take in the emergency department.
So, Swami, have you realized that you have not taken in consideration the time from injury?
Sir, we excluded the patients who presented more than 24 hours of injury, and also we excluded those patients who had any kind of intervention related to the airway or chest respiratory system.
Fair
from
enough.
outside.
24 hours is a very long time. What I'm asking is, how long do you think, or how long is it mentioned in literature that isolated thoracic trauma, changes occurring due to isolated thoracic trauma, will reflect in ABG?
Sir, there is no specific time guideline regarding this criteria, but the studies I read on this.
Better thing would be say that there is no
specific
criteria which I don't know of, which I'm aware of, because there are. And isolated thoracic trauma, when it takes at least 2 to 4 hours. I'll share with all the participants to translate into ABG. For example, you don't have it will take time to develop a pulmonary contusion. It will take at least 48 hours for pulmonary contusion to be visible on X-ray, but to translate into ABG, it at least take 2 hours. For that, compare the lung perfusion, and so definition should be from time of injury. That is a suggestion which you can correct, rather than from admission to the hospital.
Okay, thank you, sir.
Thank you. And so I request now to thank you, Soumya. So we'll move to the next presentation. So I'll just again a request. I will be just interrupting you. That may sound awkward. We'll stick to our time. So the next presenter is Dr. Vikram. I request Dr. Kamal to just introduce him, please.
Hello, Vikram.
Yes, sir.
Am I audible to you? So Vikram will be presenting a randomized control trial, which is based on a new method to reduce the surgical site infection in peritonitis case undergoing emergency midline laparotomy. So over to Dr. Vikram, please.
Yes, sir. Yes, sir. Is my PowerPoint visible, sir?
Yes, it is visible.
Yes, sir. I will start, sir. Thank you. Yes, sir. So my study will be mainly based on the emergency setting, that is patients undergoing emergency expiratory laparotomy with peritonitis to decrease surgical site infection. Myself, Vikram. My guide is Professor Manas Ranjan Sahu, Dr. Manvarelli, and Ashoka ma'am. As we know, surgical site infection is the most common cause of the morbidity in the post-op patients, and exclusively like in patients who are undergoing abdominal surgeries with contaminated wounds. The SSI rate ranges from 15 to 66%, with gram negative being the most common cause. So why we did the studies? There's scarce literature available regarding SSI rate exclusively in contaminated dirty wounds, with very less studies conducted to prevent the SSI rate. With this, our primary objective was to compare the rate of surgical site infection in patient undergoing peritonitis with emergency midline laparotomy by two different approaches, which I will be explaining. With secondary outcome to isolate commonly implicating microorganism in SSI and to see for post-operative hospital stay and rate of wound dehiscence. So it was done in emergency setting in AIIMS Bhubaneswar. It is a double-blinded randomized control trial done for 1 year duration. So inclusion criteria was any patient presenting in the emergency who is undergoing emergency midline laparotomy due to peritonitis with age more than 18 years. And the patient who had undergoing re-exploration midline laparotomy scar, known allergy and pregnancy were excluded. So with the probability of 0.05 power of 80%, we obtained a sample size of 62 using this study, and ethical clearance and CTR registrations were obtained. Coming to methodology, a preoperative antibiotic in the preoperative time duration and also during induction were given similarly in both the groups, and randomization was done using computer-generated allotted numbers, and SNOS was used for concealment. So this is the core of the study. That is two approach. That is bundle approach, as we know, will be having three interventions, proven interventions. So in bundle approach, skin painting was to be done with the chlorhexidine with respect to povidone iodine conventional approach. And after closure of the rectus sheath in the midline laparotomy, then in conventional approach, it was irrigated with normal saline. Whereas in bundle approach, after irrigation with normal saline, aqueous 10% povidone iodine dabbing was done. And it was covered with chlorhexidine pigmented gauze piece in bundle approach with respect to the normal gauze piece in the conventional approach. This was done with the idea that before and after incision for the skin commensal, which will be mainly gram positive, chlorhexidine will be more effective, as we suggested by recent meta-analysis, and also before wound closure inside the abdomen, povidone iodine mainly to counter the gram negatives. So it was patients were assessed by the blinded investigator from the post-op day to till the day of discharge in the if patient is admitted. Then after that, patient was asked to come at least on day 15 and day 30 in the OPD visit to see for SSI. This was as per the CDC guidelines. So statistical analysis was done using SPSS. Out of the 230 patients which were assessed, 68 were randomized equally to both the groups almost. And we lost 4 patients in the follow-up. So 32 were analyzed in both the groups. The baseline characteristics and also the operative characteristics like operative time and cause of perforation was similar in both the cases, with peptic perforation, appendicular perforation being the common causes. So bacterial isolates from the intraop fluid were mainly gram negative, since it was alloperforation, with E. coli being present in 50% of cases. So coming to the outcomes, our primary outcome, that is incisional superficial SSI, was significantly less in the bundle approach. That is 7 cases with respect to 15 in conventional, P being 0.05. But wound dehiscence and post-operative hospital stay were not significant. And bacterial isolates in the post-op wound also were similar. Gram negatives were predominant, with E. coli leading 40% of the cases. And antibiogram, I cannot able to go details because of
1 minute remaining.
So overall SSI was around 35%, with significant reduction in incisional SSI in the bundle approach with respect to conventional, and there was no difference in wound dehiscence or post-operative stay. 5 patients developed wound dehiscence, which was managed conservatively with Bogota bag and vac. And there were 3 deaths secondary to ARDS and septic shock. So coming to one of the important outcome, that is around 90 to 100% resistant rate were obtained for the preoperative antibiotic, which is, that is first generation cephalosporins. And also moderate degree of resistance was obtained for cefosulbactam, peptides, and aminoglycosides. And luckily they were sensitive to reserved antibiotics like colistin, polymyxin, and tigecycline. So coming to limitations of our study, sample size of 64 was a less owing to the duration of our PG chip, and inclusion of cases of stoma was a limitation. And all risk factors leading to SSI we weren't able to assess since it's an emergency setting study. And economic burden we weren't able to assess since
we have time now. So we can move to.
There was significant reduction in the SSI in the bundle approach, and since they were resistant to more common or used antibiotics, so we have to revise our pre-op antibiotic regimen, and further studies are required in this regard. Thank you.
Thank you, Vikram.
Yes,
very good study. It was planned well. My question to you regarding this study is, what was the method of randomization?
Sir, it was simple randomization, and like it was done using computer allotted randomization, sir. And concealment was done using SNOS, or like chits were kept in the emergency OT.
So have you used it a block type or
No,
do
sir,
you know
we
about
didn't use block
randomization?
randomization. Yes, sir. If we are apprehensive of reaching our sample size, we can do block randomization. But since perforation cases we are getting commonly, we didn't do block randomization, sir. We went with simple randomization.
Okay.
Okay, thank you. Thank you, Vikram. And thank you. And also, just for the paucity of time, we'll move to the next presentation. And the next presenter is Dr. Vivek.
Dr. Vipul.
Is it Vipul? Yeah, sorry. Dr. Vipul, please. And I request Dr. Yaduvir to kindly introduce him, please.
Now I want to call Dr. Vipul Goyal for his presentation. And Dr. Vipul, you have 5 minutes for your presentation and 2 minutes for your discussion. Okay, now.
Am I audible, sir? Am I audible, sir?
Yes, you are audible.
Yeah, continue.
Good afternoon, sir. I'm presenting a paper on comparison of chest X-ray and EFAST versus CCD thorax in patients with blunt thoracic trauma. Blunt thoracic trauma accounts for about 10% of trauma emergency cases that come to us. Along with chest X-ray, EFAST has also been included in most centers as part of the initial evaluation of trauma patients. Both of these investigations are used to evaluate patients and also to decide their initial management. Aim of the study was to ascertain the diagnostic accuracy of combining EFAST and chest X-ray in hemodynamically stable thoracic trauma patients, and also to determine if a normal EFAST and chest X-ray obviates the need for a CT scan in these patients. 150 patients of blunt thoracic trauma were included in this study. Patients who underwent CT thorax were included so as to provide us with a gold standard. Patients who underwent EFAST, chest X-ray and physical examination were also included. Patients less than 15 years of age, more than 72, presenting after 72 hours of injury, patients with penetrating injury or who were hemodynamically unstable were excluded from the study. Patient demographics, mechanism of injury, clinical data including findings of physical examination, heart rate, blood pressure, mean blood pressure, GCS score, ISS score were noted. Investigations like CT, chest X-ray and EFAST were noted. EFAST was done in the anterior and lateral side, anteriorly in the mid-clavicular line in the 2nd and 4th intercostal spaces, and laterally between the 6th and 8th intercostal space in the mid-axillary line. Procedures like ICD insertion and outcomes such as length of hospital stay, mortality and ICU admissions were noted. Statistical analysis was done using SPSS. Results of our study were most of the patients belonged to 20 to 50 years of age, and patients who were more than 50 years of age were 20%, and less than 20%, less than 20 years were 12.7%. 89.3% of the patients were male, thus showing the male preponderance across all the age groups. The commonest mechanism of injury was motor vehicle collision, followed by the fall from height. On comparing the mechanism of injury with the clinical parameters, such as heart rate, mean blood pressure, the data was statistically significant. When the mechanism of injury was compared with the outcome measures such as ICU admission, length of hospital stay, and intervention, it was not statistically significant. Though the significant difference was seen when the mortality of the patients were compared with the mechanism of injury, the p-value was significant. This table shows the total injuries, missed injuries, and missed clinically significant injuries. The most common injuries was the lung contusion in 24% of the cases. Rib fractures were present in 19%, hemothorax in 17%, and pneumothorax in 13%. Missed injuries were those injuries which were missed both by the chest X-ray and EFAST. The most common missed injury was the sternum fracture, followed by the scapular fracture. Missed significant injuries were those injuries which were missed both by the chest X-ray and EFAST, but led to some change in the management of the patient. There were 2 cases of hemothorax that were mixed and 1 case of pneumothorax which was missed. These missed injuries was caused by the motor vehicle collision, motorcycle collision, and fall from height. This table shows the diagnostic yield of the chest X-ray, physical examination, EFAST, and combinations thereof among the patients. The most sensitive investigation was the combination of EFAST, physical examination, and chest X-ray. whereas the single investigation which was most sensitive was EFAST. The most specific investigation was chest X-ray, whereas the most diagnostically accurate investigation was combination of EFAST physical examination and chest X-ray, whereas the least diagnostically accurate investigation was physical examination. This shows that the combination
Just
of
1 minute remaining.
Yes,
for it.
EFAST physical examination and chest X-ray can be used, but the single investigations should not be used. So to conclude, the combination of chest X-ray EFAST is superior to either investigation alone in detecting injuries in blunt thoracic trauma patients. This obviates the need to get a CT chest done when encountering hemodynamically stable blunt thoracic trauma patients. The treating surgeon should consider the mechanism of injury such as motor vehicle collision, motorcycle collision, and fall from height, as these mechanism of injuries leads to clinically significant missed injuries, and also to take into account the clinical suspicion before taking a decision. Thank you.
Okay, thank you, Dr. Vipul. Now session is open for discussion.
Dr. Vipul, why did you do the study? What were you trying to replace? Were you trying to replace CT with X-ray and FAST?
Yes,
was
sir.
that your intention?
Yes, sir. That was the intention to, as such, CT scan is not available in most of the centers in the periphery. So we wanted to do a study where we can use the EFAST and chest X-ray in combination so that we can rule out the patients where we should not be using chest, which do not require CT scan.
So in principle, would your study advocate that CT scan is not required?
Sir, if the patient is hemodynamically stable and there are no findings suggestive of any injury in the chest X-ray and EFAST, and the patient does not have the risk, the mechanism of injury, then only we can skip the CT scan.
Yes, Vipul, mechanism of injury is very important.
Yes, sir.
Because like in Western world, the difference is here patients might die of a pneumothorax. There it's very less because there's a good robust pre-hospital care, and that would be taken care at the scene itself. The second cause of mortality in United States after head injury is aortic injury.
Yes,
and it has a very poor sensitivity with either X-ray or ultrasound.
Yes, sir.
Pseudoaneurysms of the aorta. So that will be in any case missed by both of these examinations.
Yeah.
Yes, sir.
So we are not going antegrade, we are going retrograde, right?
Yeah. Just, I'm sorry, I'm interrupting. Nice point raised by Dr. Madhur. So because of paucity time, please excuse me. We'll move to the next presentation, please.
Sure.
Thank you, sir.
Thank you. And the next presenter is Dr. Vivek. And I'll request Dr. Niladri to introduce him, please.
Okay.
Vivek.
So I would invite Dr. Vivek Kumar to kindly present his next paper. And it is a prospective study to determine the correlation between clinical parameters and intra-abdominal pressure and their effect on the non-operative management of patients with blunt abdominal trauma at a level 1 trauma center. Over to you, Dr. Vivek.
Good afternoon, everybody. Am I audible to you?
Yeah, continue.
Okay. I'll be presenting a prospective study to determine the correlation between the clinical parameters and the intra-abdominal pressure and their effect on the non-operative management of patients with blunt abdominal trauma. So, non-operative management of blunt abdominal trauma is an established thing in the management of blunt abdominal trauma. So, our objectives were to assess the correlation of intra-abdominal pressure with clinical parameters like the mean arterial pressure, the respiratory rate, the serum creatinine, hematocrit, and the changes in the abdominal girth. And we also focused to assess the incidence of intra-abdominal hypertension and abdominal compartment syndrome in patients with blunt trauma abdomen. We also tried to see if there was a correlation between intra-abdominal pressure and the decision of intervention in the studied patients. And should intra-abdominal pressure monitoring be a part of regular monitoring protocol, which we use for non-operative management of blunt trauma abdomen. So we included patients with blunt trauma abdomen aged 15 to 70 years who underwent non-operative management. It was a prospective observational study, and we recruited around 174 patients out of 339 patients presenting with blunt trauma abdomen. Patients with head and spinal injuries, patients with hemodynamic instability, patients with urological injuries or a history of neurogenic bladder, or patients needing positive pressure ventilation were excluded from the study. We used a simple glass manometer which was connected to the Foley catheter to measure the IAP. This was given by Cron in 1984. IAP was measured according to the World Society of ACS guidelines at the end expiration in completely supine position. The transducer was zeroed at the mid-axillary line, and 25 ml of fluid was instilled. So sequential IAP was monitored every 6 hourly, and it was compared with intervention, whether operative or non-operative, or its correlation with other clinical parameters. The decision of operative management of the patient was only taken by the unit head, and he was blinded by the IAP values. So the decision for operative management was taken by the clinical parameters and the regular protocol of non-operative management, and it didn't include the intra-abdominal pressure monitoring. So males were the most preponderant population, and the young population was most prone to injury. Road traffic injury was the most common mode of injury found in our study. The population was very evenly distributed, with ISS and NISS roughly equally distributed in all the population. 64% population presented with class 1 shock and 12% with class 3 shock. Liver was the most common organ involved in our study. 81% of the people recruited didn't have any features of intra-abdominal hypertension. 10.3% patient had grade 1 hypertension, and 8.6 patient had grade 2 hypertension. None of the patient had abdominal compartment syndrome. When compared with ISS, the patients with ISS values more than 16 had higher rate of intra-abdominal hypertension, and a significant p-value was obtained. Similarly with NISS, but intra-abdominal hypertension was not associated with the rate of shock at presentation. Intervention was associated with intra-abdominal hypertension, and
Vivek, we have 1 minute of time.
Interventions were also associated with a number of organs involved: shock, respiratory rate, changes in the abdominal girth, and serum creatinine. These are the physiological parameters. There was significant correlation of intra-abdominal hypertension with serum creatinine, respiratory rate, and changes in the abdominal girth. And the length of stay was also associated with intra-abdominal hypertension in our study. So road traffic injury is the most common mechanism of trauma admission. Non-operative management is a treatment of choice for hemodynamically stable patient. Intravesical IAP monitoring by glass manometer is a very cheap and reliable idea. IAP should be monitored as a continuous parameter and not as a one-time measurement. Abdominal compartment syndrome is rare in patients undergoing NOM, and decision of intervention cannot be guided by IAP alone. It should be all the clinical and laboratory parameters should be taken into account before planning an intervention. And limitations of the study was it was not a randomized control study, and we didn't involve the patients with ventilatory support or those who were hemodynamically unstable. Also, post-operative patients were not involved. Thank you.
Thank you. That's time too. Yeah. You quickly move to the question answers.
Very nice presentation, Dr. Vivek. Just one question. You said class 1 shock. As we know, class 1 shock does not have any symptoms as such. So how have you defined class 1 shock, and how is it different?
Basically, we cannot differentiate between no shock and class 1 shock. So all the patients who had no features of like a tachycardia or hypertension, we took the patients as class 1 shock, because we cannot differentiate between no shock or class 1 shock. It is very difficult to clinically differentiate.
Not clinically, but otherwise?
Means we can see the pulse pressure. It is the first thing.
Base deficit.
Base deficit is also there.
I hope now no more questions. So we come to the end of this sessions. And at the outset, I'll just thank all the presenters, and I'll just request them to keep their enthusiasm going on, and wish them good research career ahead. And the second and the last, I request, on the behalf of the organizing committee, I'll request, thankful to all the respected chairpersons to take out of their time from their valuable schedule, and we are honored that you have blessed us, and thank you for your participation, sir. Thank you. Thank you, Dr. Madhur. Thank you, Dr. Kamal, Dr. Anand, Dr. Niladri, and Dr. Yadavi. Thank you.